Wickline. Sam doesn't need much introduction to this crowd, because he's one of us, and a member of the Cardiovascular Center, which I'm grateful for you joining it. And I've learned that Sam received his MD from the University of Hawaii in Honolulu. So this kind of temperatures here, I think we should all be envious. Kind of nice, but I was there last year, of course. And Sam is a professor of medicine, but also has joint appointments in this department of physics and cell biology and physiology. He's also the director or co-director of the Cardiovascular Institute at this university and Centers for Cardiovascular, I think Ultrasound and MR and other things. Sam has published extensively, over 150 papers in peer-reviewed literature, and most of it really in his work deals with applications of MRI, MR, and ultrasound to imaging much in the cardiovascular system. So he'll tell us today, it's right here, about multimodal molecular imaging and targeted therapy for these diseases. Thanks for coming.
So, I'm used to giving talks in this room. We have a class here, but I haven't been in this room for a while. Our MR class. Is it me here? I don't even know. So what I'm going to do is, I actually have two talks here. I have a really short introductory talk that deals just with MR. And in particular, I thought it might be of interest to this group to show some of the things that we're interested in looking at fiber orientation and sheet structure and so forth, just to give you an example of what might be really useful to you most immediately. Because fiber orientation could be quite important for anisotropy of conduction and arrhythmias and so forth in the heart. So that's what I'm going to do. And then after about 15 or 16 slides or so, we're going to segue into this molecular imaging topic, which concerns us not only in cardiovascular disease, but also in cancer. We do as much, if not more, cancer molecular imaging as cardiovascular molecular imaging. So I'll describe all of that in due course. So the topics are going to be cardiac MR for structure and function, because I think that we've been doing some stuff with some of the folks in this room, looking at the relationships between structure and function and ultimately arrhythmias. And then I'll go into this nanotechnology business for molecular imaging and targeted therapeutics. So here's a picture of a regular cardiac MR machine. Here's a heart done on a cardiac MR machine that you could get done yourself. If you wanted to get your heart imaged, we could image your heart. Of course, you'd have to be an experimental subject. But if you look at this, very nice picture of this heart, you can see everything moving, and you can see the walls, and the contrast is very nice. And here's the aorta, and here's the chambers of the heart, and here's the atria, and here are the ventricles, and so forth. These are very standard nowadays. It's quite easy to do these studies, quite quick. They provide terrific resolution and terrific contrast without actually having to inject anything into the body. Yeah?
What's the time resolution? The best we can get?
Let's say 50 milliseconds or something like that. So you get a frame every, say, 50-ish milliseconds. It could be maybe a little shorter, sometimes a little longer depending on exactly how you do it. But things are getting faster and faster and faster, and ultimately, if you're just looking at sort of a single slice or a few slices, you can probably do it much faster. But it isn't like echo frame rates, for example, which might be much 3 or 4 or 5 or 10 or even higher faster frame rates. But you can easily detect things like myocardial infarctions here, and you can see the heart bouncing around here. And here's a normal wall, and here's a normal wall, and this wall isn't working very well because the apex has undergone a myocardial infarction. So that's very standard, been doable for 10 or more years. New techniques, this just happens to be called balanced FFE or steady state pre-procession, allow us to do these kinds of imaging techniques. Now, one thing that's come of age lately is this scar imaging, and this is pertinent to arrhythmias. what you can do is, the pictures that I just showed you didn't have any contrast agent put in them, so nothing was injected to make the blood look bright. It's all the native signal. But in this case, you can actually inject a contrast agent. It will localize in the infarct area here. And here's an inferior lateral myocardial infarction, the white stuff here. So the bright stuff is dead, and the dark stuff is the normal heart. So now you can see where this infarct scar is all along the lateral wall here, with preservation of some of the black normal myocardium here. So this is a non-transmural infarct in part of it, but transmural in other parts of it. So you can look at the resolution to the millimeter type scale to look at these scars now, which is very difficult with other imaging modalities like PET, for example, or nuclear imaging. And you may even be able to do the same thing with CT, because the contrast agents that are used with CT can also image scars like this. And they don't look too different from this. So MR or CT late hyperenhancement is going to give you the picture of the scar, and you can see little tiny scars all over the heart. So this might be pertinent to some of the things that are going on in arrhythmia modeling. The other thing that we do is called tagging. That basically means you paint some stripes onto the heart, not permanently, of course, and they eventually go away, but as the heart contracts and relaxes, you can see these things twisting around, and you can plot the motion of the heart with finite element models like this and compute strain values in a bunch of different directions. And so that will tell you what the fibers are doing within the heart tissue itself. So you've got normal ejection fraction and cardiac motion, you've got infarct scar imaging, you've got the ability to measure strain to a certain resolution. And you can even do this in 3D, where you can look at all of these little nodes bouncing around and look at each part of the heart by doing these finite element models. You can analyze something called torsion, which basically just tells you how much the heart is twisting and untwisting in time. And torsion might be the difference in the twisting between, as we've defined it here, between the apex and the base. And the base will twist one way, the apex will twist another way. And this is like why the heart wrings the blood out. You've heard about this. As it contracts, it not only thickens the walls, but it twists like this, and it kind of like a wringing out of a towel. So the blood gets ejected by this wringing motion. W-R-I-N-G, ring, that kind of ring. And it turns out that the twist of the heart is conserved in humans, rats, and mice. And so this is common. The amount of twist that the rotation of each of these segments is basically the same in humans, rat, and mice as you go from the apex to the base. One of them turns one way, the mid-wall doesn't turn much at all, and the apex turns the other way. And this net twist is really no different. So this is a common contractile mechanism in these animals here. So twist is very important, and it also turns out that if you take twist and you calibrate it according to the length of the heart, you get what's called torsion in this literature. It's argued in the engineering literature whether that's really torsion or not, but that's what it's defined as in this literature. But it turns out torsion is larger in smaller species. So the twist is the same, and if the heart is shorter, then the torsion has to be likewise larger. And so men have less of that than rats or mice. So we've used these kinds of indexes to look at the function of genetically engineered or abnormal subjects like the MDX mouse, which is a model of Duchenne's muscular dystrophy, where the dystrophin, which is part of this dystrophin complex here and connects the inside of the cell, the sarcomeres, to the outside of the cell, is abnormal. And this MDX mouse mimics the human muscular dystrophy disease, although it's milder in the mouse because they have no clinical sign of cardiomyopathy, although they do have abnormal hearts. And what you can do with these sorts of measures of twist and torsion and strain is to detect problems in these in the force transmission that would occur between the sarcomeres as they contract and the outside of the cell, which connects up to the whole rest of the heart and causes the heart muscle itself to contract and then shorten and then push the blood out of the heart. And so one of the things that we wanted to do was to look at that, and we've looked at it in mice, and we've also looked at it in patients, and we just published this article using torsion and strain analysis in the cardiomyopathy of patients with muscular dystrophy. And indeed, it does show that even if you have normal cardiac contractile function, so if you're looking at these hearts and they look like they're beating normally, they don't have normal strain and they don't have normal twist and torsion. And the only way to figure that out is to do these special kinds of imaging tests. And then you can tell that, in fact, these patients have abnormal hearts. And it turns out that a lot of these patients will die of heart disease, not just their muscle disease, which would cause a breathing abnormality. And so you can find out about that very early by doing these sorts of tests. Again, just another way of looking at abnormal heart function, regional and global, with a kind of a different test other than ejection fraction, for example. And we'll go on to look at not just the function of the heart, but the structure of the heart. And as you know from studies from many years ago, in fact, the heart is made of plies of fibers like this. And those plies are kind of like the plies on a tire. They rotate from the outside of the heart to the inside of the heart by at least 150 degrees. So you've got many of these little plies that are laid down where the fibers are pointed one way along the endocardium and another way along the epicardium. But not only do they have a fiber orientation that changes from the endocardium to the epicardium over 150 degrees, they also have these sheets. So there's higher orders of structure of fibers in the heart. And the sheets look like this. You can see these kind of linear streaks here. They're going this way over here and this way here. Well, these are called sheets, and they're bundles of myofibers. So you've got a primary organization, which is fibers, and then you've got bundles of fibers organized into sheets. And both of these kinds of structures are very important for the way the heart works. We've been doing some work with Dr. Efimov looking at diffusion tensor mapping, or diffusion tensor magnetic resonance imaging, to map the anisotropic water diffusion in the myocardium, because that tells you what the fiber orientation and the sheet orientation is. You get primary and tertiary eigenvectors out of this kind of an analysis. The reason that this is the case is that the largest diffusivity of water is along a fiber, because the water diffusion is restricted to the fiber orientation. So it doesn't go across the fiber, it goes along the fiber. And so if you work out this tensor, you can find out that, in fact, you can calculate the eigenvalues and eigenvectors and figure out exactly that the water diffusion maps out the fiber orientations. And if you take some of the other eigenvectors, it will map out the sheet orientations as well. And I won't go into how that all works, but what it looks like is this. This is kind of a cartoon. If you look at the principal diffusion vectors, they might indicate fiber and sheet orientations. And here's a diffusion tensor, it's actually sort of a cartoon, showing the diffusion being longer this way, or faster actually, than it is this way, meaning that it's much more likely for water to go up and down than it is across, either in the X or Y direction. And that's about the shape of a fiber, for example. So these will tell you what fiber orientations are, and kind of about what their lengths might be, these cardiac fibers. And if you have disarray in these fibers, you get a fatter ellipsoid like this in the diffusion tensor when you solve that. So this will tell you about fiber disarray, and that's actually quite important for arrhythmias, as you might guess. The other thing you can do is you can construct these myofiber helix maps, and I'll just show you here. If you look at this, it goes from -100 to +100 degrees from the endocardium to the epicardium. You can slice and dice this up, and here's a systolic picture, and here's a diastolic picture. So you can look and see where the fibers are at all parts of the heart cycle, in every part of the heart when you do this diffusion tensor mapping. You can also calculate, based on the other eigenvectors, the laminar sheet structure, as we showed here. This shows you the orientation of these sheets from the endocardium to the epicardium. So they're kind of going this way up near the base of the heart, kind of like this. They have some bends and they have some folds in them and so forth. At the midwall they look kind of like this, and the apex they're looking kind of like that. So now you can look at these higher ordered structures in the heart rather than just the fibers. And the interesting thing about doing this is that if you, as Junji Chen showed recently in the American Journal of Physiology, if you cause the heart to contract, and you can really only do this in a heart that's in a Langendorf preparation for the moment, because you can't measure this on a human being. It takes too long. But if you arrest this heart in systole with barium, what'll happen is that you can measure these sheet orientations as they change from diastole to systole, from end diastole to end systole with the heart contracted by barium, and you can see that these sheets now flatten out, go from diastole to systole, diastole to systole. As the heart both twists like this, the sheets will flatten out, and it turns out that these sheets, the motion of these sheets, we've calculated could account for as much as 50% of the ejection of blood, rather than just simple wall thickening, for example. So if you just had wall thickening, you would get some blood ejected, but you got to have this twisting, sheet flattening kind of thing going on to get the rest of the blood ejected out of the heart. So it's very, very complicated, the way this all works. But this is fundamental to the way a heart ejects blood. And in fact, because of this higher order organization, there's some opportunities to have alternative sources for anisotropies in electrical conductance and material properties as well. So I just bring that up as a sort of introduction to some of the other stuff that we do. Any questions on that? That's a whirlwind tour, but those are the kind of things that you can do with MR that some of them you can't do with any other technology. All right, we'll move along to nanotechnology and the new future of disease management. So
I have a question before you.
Yeah.
Have you tried to look at heart failure and the models of heart failure and independently of the electrical sequence of activation and mechanical sequence?
We haven't done that yet, but
Now
we're being made to do that by this guy right here.
Models of heart failure.
Yeah, so for example, if you take the thing we're doing with these rabbits that Igor has, which have they're a model of asymmetric septal hypertrophy with fibrosis and fiber disarray, for example. All of those patients die of arrhythmias. They don't die of they don't die of obstruction. They die of rhythmic deaths. And so that's one thing we're looking at. We have not yet taken this to looking at the other forms of heart failure, for example, the muscular dystrophy, the MDX mouse, but we're on the way to doing that. We have looked at infarcts, and so there's a substantial amount of fiber disarray in the infarct zone, and in fact in the border zone, which is quite interesting. So there are opportunities for studying
There's a
all
whole class of patients that have, the left bundle branch block morphology,
Yeah.
delayed left lateral wall.
Yes. Yes.
And it's not clear what's happening in terms of, because it seems that if you go through resynchronization therapy, cardiac resynchronization therapy,
Right.
and you bring back the synchronization between right and left by enhancing activity of the lateral LV, it doesn't help mechanical synchrony. And it really is a fascinating thing that people have got to...
We just have to have somebody donate one of those hearts, because we got to take it out. The problem with doing diffusion tensor mapping is that you've got to apply gradients in a bunch of different directions in order to follow the water as it goes through a random walk, and that takes a lot of time.
But you can do tag MRI.
Yeah, but that won't tell you the fiber orientation. It'll just tell you the kinematics. It'll tell you the motion. But the other side of that is the structure. You'd really like to do that in a human, but it's really challenging. But it's a good point.
The third side of it, of course, is the electrical activation
Yeah.
sequence. And
Yeah.
even if you don't do the structure,
Yes.
there is no understanding of correlation,
Yes.
no failure of correlation between mechanical contraction and electrical sequence in those type of patients. It's totally, you cannot predict one evolution with a normal heart. You can say mechanical activation, cardiac activation, follows electrical activation, because one initiates failure. In these hearts, this whole theory goes apart. So
Yeah.
really not
No, that kind of stuff would be certainly doable in experimental models. Quite yet. Humans, maybe.
I have one technical question. So when you do this in arrested hearts, so there are a couple of issues. One is gap junctions are uncoupled, so you alter essentially isotropic properties already, and the diffusivity tensor
Right.
will be altered.
Right.
And second issue, there was a recent paper from Fujimoto's lab from MIT on optical coherence tomography
Mhm.
in cardiac, actually not cardiac, doesn't matter, different tissues. which were also arrested and fixed with various protocols. And with OCT, he also looked at how tissue changes its properties. So my question is it possible, I understand the limitation that it really takes a long time to do diffusivity, Tensor MRI. Is it possible to compare intact tissue with intact cell-to-cell communication and hopefully intact Tensor of electrical activities and cells which are...
Well, what happens is you can apply, you overload these with barium, basically, and that causes contraction. It's reversible. So in theory, if you didn't screw anything up, you could make your structural measurement, which isn't impacted by barium in terms of...
This probably will still uncouple connections.
But when you wash the
Even
barium out,
reversibly.
the heart is normal again. And so you can do this time and time again. So yeah, it may do that, but it doesn't do it enough to bother most people. But yeah, I mean that could happen. So if you washed it out, that would be your only opportunity to do that experiment. And then,
but in fixed hearts, it's usually just in PBS or.
Well, these really aren't necessary. Well, let me put it this way: they get fixed in that position, but because we then want to take our time to image it, so you extract them and then you fix them in that position. But you could do it probably other ways. We just haven't done it that way. But yeah, there's some opportunities for thinking about that sort of stuff. Okay. Other questions on MRI stuff? Nanotechnology. So one of the reasons, you've seen some of the kind of contrast that you get when you look at a regular MR. You've seen that you can put contrast into the body and then it goes interesting places like infarct scars and you can make those diagnoses. But what if you wanted to image a molecule? It's too small to image with an MR machine. So in order to image a molecule, you have to have a contrast agent that goes specifically to that molecule and targets it somehow. And then you take a picture of the contrast agent that's been targeted to the molecule. That's what molecular imaging is in our hands and in most other hands too. Like PET is molecular imaging. You image positrons emitted from labeled palmitate and so forth. So that's a molecule that you can find by coincidence detection. But in this case, we're going to do molecular imaging, not just for the fun of it, but we want to look for the molecular causes of disease, not just the manifestations of disease. So not just the fact that there isn't a normal twist, or the fact that you have a heart attack and a scar, or you have fiber orientations that are disarrayed. Those are all subsequent events that occur, after something is going on early, and you want to image that early event with molecular imaging so that you can presumably interrupt the course of a disease before it gets to the point where you have a heart attack or a stroke or cancer that spreads and so forth. So molecular imaging basically is like it's like in vivo immunocytochemistry in a way, but with really much lower resolution. So you're not really imaging the molecule. You're tagging the molecule and imaging the contrast agent that went along with the tag. And so the other thing that we do is we develop new methods for delivering drugs and genes. Having done this molecular imaging trick, knowing what's there, now we can make a good guess as to what therapy we should use. Then we put it on the actual imaging agent, and we target that back to this site, and then we can deliver that. And so imaging, and then therapy, and then follow-up is what this business is all about. Site-targeted therapy. You all know what nano means. It's this of a meter. It's a lot of zeros. It's 1/10,000th the width of a human hair, or 3 to 5 times the diameter of a single atom. It turns out, despite the scare of nanomedicine, and in fact there was an article in Science not too long ago about the toxicity of nanoparticles and nano devices and so forth. The body is a nanomachine in and of itself, and nanotechnology basically is used all the time. For example, here are some immune cells that communicate through natural nanotubes. This is how this guy tells this guy that there's an antigen there that needs to be presented and then processed, and then other antibodies need to be produced. So this is a normal process, and in fact, one of the oldest kinds of nanoparticles is a bacteriophage. This is a virus, basically, that that looks kind of like this. If you see an electron micrograph of it, it has a head with some kind of genetic material in it, DNA or RNA. It has an injector piece here, and it has a little nozzle up here, and it has some grabbers down here. And this thing basically grabs onto a cell through recognition sites, and then because when this grabbing event occurs, a signal comes up here to pump the DNA or RNA out into the cell, and that's how it transfects. So this is a little nano machine, and all it does is it grabs on and injects its stuff, and then it's done with its job, and then that stuff goes in, hijacks the cell DNA machinery, and makes more of these to do the same thing. So these are all things that sort of are around us all the time. So what we've done to take advantage of molecular imaging is to develop certain types of molecular targeting agents, and the one that we're using now is a liquid perfluorocarbon nanoparticle emulsion. And I'll describe that more in just a minute. But there are all kinds of nano tools and nanoparticles. You can make them out of silicon if you want. You can make them out of polymers or copolymers or tripolymers. You can make them out of lipids. An LDL particle is basically a nanoparticle. An HDL particle is a nanoparticle. And there are various and sundry ways of making synthetic tools for carrying drugs and doing imaging. But in our case, you've got this liquid perfluorocarbon, and it's surrounded by a monolayer of lipid here, not a bilayer. And this is a surfactant. And this thing is about 200 nanometers or so in diameter. And because this is a lipid here, you can take other lipid pieces and plug them into this membrane and functionalize this particle by attaching other sorts of things to that lipid that anchors into this membrane. And you can put targeting agents or molecular Velcro, if you will. You could put imaging agents like gadolinium, which is the contrast agent used for MRI. You could hook it onto a lipid or a fat and put it in this membrane. And you can put drugs in here directly into the membrane, dissolve them in the membrane. It turns out that this perfluorocarbon, and I'll talk about why I've made a point of this being fluorine in here. It's a heavily fluorinated carbon-based molecule. Remains liquid at body temperature. There are some of these things that are used that are made up like this, but then they turn to gas and they create bubbles. And ultrasound uses these bubbles in order to use it as a contrast agent. So this is not the gaseous perfluorocarbon, but the liquid perfluorocarbon, and it remains like this. And it's pretty stealthy. It'll circulate around in the bloodstream with a beta elimination rate of about somewhere between 3 and 5 hours half-life, if you will. So 5 half-lives is a day or so, and so you can inject say 100 trillion of these particles in just a few cc's, for example. Now, you make this by a process called microemulsification, and basically you squirt this out under high pressure through a frit. It's 10 to 20,000 pounds per square inch, and you put it in a bottle, and it'll stay reasonably intact for a year or two on the shelf. And so this is kind of what it looks like here. It's sort of a milky substance, and it's a little like salad dressing. Again, it's a little more fancy, of course, and a little more uniform, but it's kind of an oil and water suspension, if you will, and that's basically what milk is. So it looks milky, and so it's a suspension. Now, if you target it, for example, here, it's targeted to fibrin, which is the stuff that makes a blood clot. Here's a blood clot by scanning EM. Here's some red blood cells that are crenated, and here's some fibrin strands. And when you put a fibrin antibody on here, it attaches to the fibrin, and you can see these little nanoparticles that are now attached to the fibrin through the interaction of the fibrin antibody and the fibrin sites that it's going to bind to. And so now it's on this clot. So now what do you do with it? Well, here's one of the first things we did with it. We made a clot in the neck of a dog with anodal current, so that causes platelets and fibrin to accumulate. And it's very hard to see these things with conventional ultrasound at 7.5 megahertz. There's actually a clot here, but you can't really see it. This is the transducer up here applied directly to the neck of the dog, and here's the metallic anode. The clot's there. But only when you put these particles in does it get around the clot, bind to the fibrin, and cause an increase in acoustic reflectivity. It turns out the backscatter, or the acoustic reflectivity, is enhanced by at least 20 decibels, which is a huge amount for a little tiny particle. kind of interesting. So this is thrombus detection or clot detection, and the first thing we used this for was ultrasound clot detection. You can also image, for example, the earliest stages of atherosclerosis. So all of us, I presume, have eaten a bit of cheese today, and so we're facilitating the growth of plaques in our aorta. Maybe that's not going to cause any problems in the future, but it turns out that the higher your cholesterol, and cheese has a lot of it in there, the more likely you are to develop plaques or hardening of the arteries or atheromas. And if you feed a rabbit a high cholesterol diet, what will happen is one of the first things is it starts taking up the cholesterol here in the intima, which is out here, and here's the media and here's the adventitia. These are the layers of the aorta in this animal. But these blood vessels out here toward the outside of the wall start growing very profusely. And the reason for that is that if you're going to grow one of these plaques, like these atherosclerotic plaques, you need a blood supply to do it. Just like when a tumor grows, you need a blood supply to keep the tumor growing and to metastasize. But when you grow a plaque, it's kind of like a tumor, and it needs a blood supply too. So it calls out and says, make more blood vessels, and that's what these are. These are stained for alpha V beta 3 integrins, and this is called the vasa vasorum, or the vessels around the vessels. And these are plethoric, as seen here in this pig coronary artery image done by micro-CT. This had a contrast injection of iodinated contrast. This was done by Wilson and the group up at Mayo, showing this plethoric vasculature out beyond this coronary artery. So this is an early event, angiogenesis. It's an early event in tumor growth, and it's also an early event in atherosclerosis, and it's important to know about. So if you target these things now to the vessels, here or here, you target them now with an integrin targeting molecule. So you put on something that'll bind to alpha V beta 3 integrins, never mind what it is. In our case, it just happens to be a chemical. So it'll go bind to these things, and then you can make a picture of that. If you put gadolinium on it, you can make a picture with MR. So these are angiogenesis targeted nanoparticles imaged with MR, and here are sections of the abdominal aorta that have this angiogenic component here. Now this fluorinated nanoparticle will bind here, and where the color is where the signal is high in the wall of the vessel, where these vasa vasorum are growing under cholesterol drive. So this is a cholesterol-fed animal with a targeting agent. Here's a cholesterol-fed animal with no targeting agent, not too much signal. Here's the aorta in cross-section like this. Done on, by the way, a regular 1.5 Tesla imager, what you'd use in a human being, so this will work in a person. And here's no cholesterol feeding, normal diet, and a targeted agent, not much signal there. So again, quite easy to do this, and you can see these signals developing within an hour, and they go up for a couple of hours or so. So now you can say, I can find the earliest sources of disease by looking at angiogenesis in plaques. You can do the same thing in tumors, and I'll show you in just a minute. Well, the other thing you can do, there's other things that you can image and other ways to image things. And so nanotechnology can image with ultrasound, with MRI, and here's a fluorescent picture of VCAM, vascular cell adhesion molecule. So in this case, there's an antibody pasted onto the nanoparticles, which go now to this injured arterial segment, and this happens to be a mouse that had a laser injury to a cremaster arteriole, and this is intravital microscopy, and this collection here is a fluorescent readout of particles that had a fluorophore put on them, and so now they shine where the injury was and where the VCAM was upregulated due to the injury. And so now they're sticking there, much like white blood cells would stick there, when they encounter adhesion molecules in other kinds of injuries. So now this is VCAM fluorescence of targeted nanoparticles. We can see the later stages, or unstable stages of disease. So this is fibrin targeting of disrupted plaque, or a plaque that's actually broken and maybe has been associated with a mini stroke or angina or a small heart attack, if you will. So this actually is a sample of a human carotid artery, which is taken out by a surgeon. And there's lots of fibrin in these, which are deposited as the artery breaks, and then it ruptures, and then it heals up again, because the clot actually clots off the break, and then it's sort of taken up into the into the wall of the vessel, and there's lots of this fibrin around as the vessel breaks, and this plaque continues to get bigger and bigger and bigger. Here's the normal media right here, and all of this is the intima plaque right here, or the inner lining of the vessel, which has been markedly thickened by this fibrin, atherosclerotic cholesterol gruel, if you will. It's a real mess. So if you could target this to some of this kind of stuff with fibrin targeting again, and this is an antibody, you might get something that looks like this. In this case, what we're showing is a disrupted plaque ex vivo. This was a carotid specimen taken out of a patient who had a mini stroke. So what the surgeon does is he just flays open the neck and opens it all up and goes in and cuts the artery apart and just scoops out the inside of it. And we got that piece that got scooped out. And so here you can see these hot spots on the side where this plaque has actually ruptured here. And this is in a test tube, so we incubated these nanoparticles targeted to fibrin with these carotid specimens inside of this test tube and took an MR picture, again at 1.5 Tesla, the clinical sort of imaging field strength. And you can see these hot spots. Here's the lumen right here. A little hard to see, but the blood would flow through there nicely, yet it's still been disrupted here and here because fibrin's exposed there. And now these particles can attach there, and you can see where the disruption has occurred. And now, if you can do this, that would allow you, for example, in a patient who's even asymptomatic, let's say, to do this test, if you, say, had a reason to do it, and then you could find these hot spots and say, oh, it's already broken, because these things actually don't get out of the bloodstream. They won't go in the wall necessarily, but if something like fibrin is on the wall, it's very abnormal. You shouldn't have fibrin exposed on the wall, and it'll show these hot spots where the plaque rupture has occurred. Now you could make up your mind as to what you want to do. Yeah?
I guess these plaques are generally like at a sort of stable state. These molecules, do they make it less stable? Can they possibly?
No, actually, it's sort of interesting. What happens with these plaques is they go from a vulnerable state to an unstable state to a broken state, and then they heal up. So they're always doing this cycling thing, and they break and they progress in severity in steps. So it's a sort of a step function. So it's not like you're at 30%, and next week you're at 31% stenosis, and then 32. It's not a linear. It's a step function. Every time they break, they get worse, and they get worse by a lot. Sometimes they might be at 30% stenosis. They would break, and you'd go on to a complete occlusion. Who knows? But they all have this fibrin here, and it turns out this is a very small thing. It doesn't build up and cause an obstruction in and of itself. But it's too thin of a layer to actually measure by any tool that we have once it's deposited there. And in fact, it's very likely that this is going to be helpful because we can put drugs on here that will actually dissolve clots or make the thing heal up better by putting various growth factors on or things like that. So I think at least it's the hope that this would be therapeutically beneficial as well as diagnostically accurate and sensitive. What about the final stages of disease? Well, here's a picture of a ruptured plaque with a big thrombus in the middle of it, and you can see how nasty this is. But look, it's got a pretty big lumen, but all of a sudden it broke and caused a complete obstruction. Say this might be a 50% stenosis or something that cardiologists would say, well, I don't really care that much about a 50% stenosis. I can't even put a stent in it. I can't bill for it, so why do I care about it? Well, you care about it because most of these plaques that rupture are really kind of mild-looking plaques by angiography. And this can happen lickety-split. In fact, you could come in and have this kind of a picture on your angiogram or look at the lumen size, which might look good, send the patient home on some aspirin, and tomorrow they might drop dead. And that happens about 50% of the time. People just drop dead without really even knowing about it. A lot of them are due to arrhythmias, but a lot of them have had this problem before. And you can again take your fibrin targeting molecule, and here's a picture of a clot that's been made in the neck of a dog, again, hot spot imaging with MRI, where this sticks to this, and in about 30 minutes you can see this signal developing, and you can diagnose the fact that there was one of these, like in this artery. And so these are pretty common in people who have pulmonary emboli. They're in the lungs, they're in the legs, so there's lots of reasons. They're in the heart after you have a heart attack. Lots of reasons to want to diagnose thrombi. What is unique about MRI as compared, for example, to nuclear imaging? Well, it used to be thought that the signal that you got out of an MR machine which is sort of a black and white or shaded gray sort of signal. You can do proton imaging, which is the usual thing to do, and that causes with a contrast agent, when you put it in there, causes the signal to brighten up. But there's lots of bright spots and there's lots of dark spots, so you'd like something more unique. For example, in nuclear medicine, when you image a radionuclide, you know the only reason that you got that signal is because you put that specific radionuclide in there. Can you do the same thing with MR? Yeah, it turns out you can't. If you image fluorine, at least, and there's some other ways to get around this that we won't go into. But one of the opportunities that we've had is to image not only protons, which is most of the imaging that we do, but to image fluorine as well, because these particles are stuffed with fluorine. There's a large concentration of fluorine in them. And if you fix your imaging machine up so that it's sensitive to exactly the resonant frequency of fluorine, you can actually take a picture of it, or at least get its spectrum or some combination of those two things. So we were helped in this process by Philips Medical Systems, so we can do fluorine imaging of the particles, not just proton imaging because they contain gadolinium, which affects the proton signal, but the fluorine itself we can image directly. So here's a picture of a clot in one of those endarterectomy specimens in a test tube. Here's the specimen one end and the other end down here. And this is a picture of the fluorine signal from those nanoparticles that have now bound to that clot. So here's fluorine, and here's another little bit of fluorine. And you can measure the spectra of fluorine just like you do NMR, for example. So here's one kind of a perfluorocarbon called a crown ether. Here's another one with some different kinds of peaks. But here's the actual picture of this clot now made with fluorine imaging, not with proton imaging. And this signature is unique. You couldn't confuse it with anything else. If you get this signature, it's because you put nanoparticles there. Because there's no measurable fluorine or imageable fluorine anywhere else, usually, unless you had some other reason for having fluorine there. Like, for example, you used a chemotherapeutic agent that had fluorine, which people have done. It turns out, here's some of the stuff that Ann Neubauer has done, calculating the amount of nanoparticles and the concentration of nanoparticles based on the fluorine signal, and this is fairly linear, at least in this regime. So if you do the fluorine spectroscopy and measure the area under the curve, for example, you could calculate the concentration of nanoparticles if you know a little bit about how big they are and how much fluorine's in them, with a few other assumptions. So now you can see nuclear imaging is quantitative because the count rate is related to the number of things that you put there. Well, now you can do the same thing with MR, let's say, because the area under the curve of the fluorine spectrum is related to the amount of fluorine that's there, and that's related to the number of nanoparticles that's there. So a unique signal, potentially quantifiable. Here's just another example from one man's papers that shows, indeed, looking at these kinds of endarterectomy specimens. Here's the proton image, kind of fuzzy. Here's a kind of fluorine image. And here's a quantification of that where the fibrin is in nanoparticle concentration. And these are in nanomolar up here. So that's about 1 nanomolar to 500 picomolar or so forth. So now you can compute these concentrations of nanoparticles, at least from these simple specimens in these kinds of experiments. Here's another use of particles for looking at angioplasty. Here's an example of an angioplasty coronary. Does everybody know what an angioplasty is? It's really rude. You take this balloon and you stick it in an artery and you blow it up and you just rip the artery to shreds. You know, if you're a surgeon or a cardiologist, you love doing this. But the reason you do that is because you want to compress these lesions up against the wall and open up this vessel so that you don't have angina or chest pain due to occlusion or atherosclerosis. So this is alpha V beta 3 targeted nanoparticles. Again, the proton signal of an artery that's been treated with balloon injury here. Here's one that's normal. So these particles will accumulate because there's a lot of alpha V beta 3 in the media, and it's also upregulated after injury. So you can now see the injury response or the inflammatory response to these kinds of injury situations. Here's another one that's called it's a type of collagen, so you can target that too, but the signal's not quite as bright. I'll move on past these. Go into tumors, and then we'll get into therapeutics. Here's a mouse. We're imaging angiogenesis, the same as we did in those plaques. This is at 1.5 Tesla. Here's the mouse body. There's a tumor back here. When you add alpha V beta 3 integrin targeted particles, after about 120 minutes, you get a nice signal showing up in this little tiny tumor in the back of this mouse, imaged again at 1.5 Tesla. The mouse is, the syringe that we use to inject it's almost as big as the mouse. This is a 2 millimeter melanoma tumor, which has created angiogenesis around it in order to continue to grow and metastasize. And you can image that angiogenesis and therefore image the tumor, or at least the blood supply of the tumor. And that's an important thing to do because that's how these tumors grow. So if you know where their blood supply is, you can kill it. I'll show you how we do that in a bit. Here's another kind of a tumor. It's called a BX2 tumor in a rabbit leg, and this is angiogenesis there too, and the signal goes up after about 60 minutes, and you can measure that. So these little hot spots here are where angiogenesis is developing to support this tumor growth. Skip that. We're also doing stem cell stuff like everybody else. We're loading them and following them around. So if you want to inject stem cells and see where they go, track them around. Here are stem cells. These are endothelial precursor stem cells with all these positive markers on them that have eaten up the nanoparticles. So they went to lunch. So you sprinkle them on, and these cells will actually ingest them. And what happens is these are made fluorescent, so you can see them inside of the stem cells. Then when you inject these stem cells, this is the femur bone of a mouse, and this is an injection of, let's say, 1 million cells made into the thigh of an animal. Now you can take a picture with fluorine to look at the fluorine signal from these cells, which is distinct, and see where the stem cells are. And you can actually kind of track them around over time and watch them move into other places of the body. What about therapeutics? The key is to bring large payloads to the job site. So the way we do this is we use the nanoparticle here, but we, in some cases, will dissolve the drug into the membrane, particularly if it's lipophilic, hydrophobic. It'll dissolve in there and stay in there. You can lock it in with various techniques, but you basically put it in here. When this contacts a target cell membrane through its ligand, which here is shown as an antibody, these lipids and this lipid surfactant layer will come off and go into this target cell membrane, and vice versa, these lipids will go off in the exchange. So there's this little pathway of lipid exchange that's going to occur here, and this also fuses. And so you can see what happens here. If we've labeled this particle with rhodamine, which is a fluorescent dye, we made it turn red, you can see this streaming off of red labeled lipids going into the membrane of the cell, which has been stained green or transfected with green fluorescent protein, which is linked to endocytotic markers, Rab5 and Rab7. You can't see this in here, but this is stippled red inside here, not contained within any endosomes. But what happens is you have this floating off or lipid exchange or lipid mixing from this particle to this membrane. The membrane's on the outside, and these green fluorescent protein markers are on the inside of the cell. Here's the nucleus. But it comes off rather quickly and will go into the membrane and flip over and distribute itself into the inside of the cell within, say, 10 or 20 minutes. So you can basically download or dump off a whole bunch of lipophilic stuff into a cell by this, what we've called contact-facilitated drug exchange, because it takes this binding event in order for this to occur. If it doesn't bind, it doesn't do this very well, because it's got to get close enough for lipid exchange to occur. And it's rapid. Here's doxorubicin that's been put into the particles in the lipid membrane. And you can see after about 20 minutes of the available doxorubicin in a particle, almost all of it's inside of the cell or transferred if it's targeted. If it's not targeted, not much of it goes into the cell. So the difference between this and this is the specificity of targeting for drug delivery. So you can target these, it'll go into the cell if it's specifically bound, and you decide what it binds to, and it's very fast in certain cases. So here's just an example of doxorubicin fluorescence in the nucleus of a cell after half an hour, for example. So doxorubicin already has gone into the nucleus where it does its job. And here's a nuclear stain, and when you put this one on top of that one, you get a purple thing. You can't hardly see the cells here, but this is very rapid, taking only about 20 minutes. So one thing you can do is take these now, and that was in a petri dish, and you can target the doxorubicin-containing nanoparticles. Doxorubicin, by the way, is a really good cancer drug. It's very potent. And one of the problems with doxorubicin is it causes heart damage. So you'd like to use as little doxorubicin as possible in order to treat the tumor, but at the same time, you need enough of it there, but you don't want to put a lot of it in the serum. So here's a great way of doing that. Put it on a nanoparticle, which only will deliver the drug to the cell of choice. Use a very low serum concentration, get it directly to the cell, and put it in the cell very quickly in about 20 minutes, for example. So that would be the strategy. Low serum doses, high local concentrations, specific drug delivery. And so here's an example of alpha V beta 3 targeted doxorubicin containing nanoparticles and tumor cell numbers here. Here's a control treatment, and this after like a week has knocked down the number of cells to half with only I think one or three treatments. I think it's one treatment in this case. But here now the tumor's dying because it's rejecting. And these are all basically not tumor cells but inflammatory cells with these targeted doxorubicin containing nanoparticles. And here's happy tumor cells. They're all viable. Here's another example of nanoparticles loaded with an anti-angiogenic drug called fumagillin. This is a very lipophilic drug, hydrophobic, which reduces tumor growth. And here's the tumor size in these VX2 tumors in rabbits. It goes from here to here after about 3 weeks of treatment and 3 doses only. And the amount of angiogenesis around that tumor is also reduced concordantly. And so that's how this works. It's an anti-angiogenic compound that causes tumor regression by killing the blood vessels. Here's an example of treating atherosclerosis with anti-angiogenic compounds, because atherosclerosis requires angiogenesis in order to grow. So here's at the time of treatment another rabbit aorta. All this color is where the alpha V beta 3 targeting is. Now, if you use this with a drug, one dose, a week later, all this alpha V beta 3 targeting has gone away. So now you've effectively reduced the amount of angiogenesis with fumagillin, which is delivered directly and locally to these angiogenic sites in this atherosclerotic plaque here in the rabbit. And if you don't put a drug in there, it keeps growing. So again, very specific, single dose, very small serum concentration, but very high local concentration. And if you don't do anything after, you knock this down after about a week, if you don't do anything else, you can kind of follow this with the same imaging tool and see that the angiogenesis is coming back. And so here you've seen that the fumagillin nanoparticles, which treated this, now you just give regular nanoparticles here on out. You can follow the response as it recurs, as this angiogenesis comes back, if you don't do anything else, because it's still under cholesterol drive in this case. And nothing happens with the control. So you can follow the process and decide then what to do about that. Like you might have tumors. Say, well, I killed the blood vessels for the next couple of weeks. I'm going to image it again and see if they came back, and I'll give another dose. So instead of saying, I've got 6 courses of chemotherapy to give and good luck, you're going to be able now to say, I can monitor the exact effect on these pathologic situations. Here's another kind of a drug that we've put onto these particles. This is actually complex streptokinase, which is a clot buster, thing that dissolves clots. This is an ultrasound picture of the surface of one of these clots made in a petri dish. And here we've put streptokinase on the nanoparticles, and we've added plasminogen. The streptokinase turns plasminogen into plasmin, and that chews up the clot. But you can see the corner of this clot basically dissolving over here. Never mind how this picture is made. It's called an acoustic micrograph. But if you don't put plasminogen in there, there's no action, even though you have streptokinase on it, and the clot's very stable. We've seen these things disappear totally in about 30 minutes in a petri dish. They just get eaten up from inside and outside, and so this would be a way of targeting a clot-busting drug to the site where it's going to be most active, to the clot. For example, binding to fibrin and then activating plasminogen on the surface of the clot without having to give it systemically. And it does cause other forms of problems like bleeding in the brain and so forth if you use it systemically. So here's an opportunity to enhance its potency and reduce its toxic side effects. Maybe the last thing I'll show you is that you can also augment some of these effects by using ultrasound. And so here's an example from Kathy Crowder in our lab of using ultrasound radiation forces to enhance nanoparticle cell interactions. So basically, ultrasound is a mechanical wave. it propagates longitudinally, and it has a pressure component. What it'll do is it'll push things. It exerts a force on them. It's called a radiation force. The force it exerts on particles will push them away from the transducer. This is the primary radiation force. And the secondary radiation force aligns particles perpendicular to the direction of insonification. So to show you what happens with our nanoparticles, here are C32 melanoma cells in a petri dish, and the transducer, this is a regular imaging transducer, by the way, so nothing fancy about this. So when you turn this on, the force causes the particles to move away from the transducer, which is here, and to line up like this. They kind of stick together. When you turn it off, things go back to normal. So this, you can turn it on and off and on and off and see these things hallucinate like this. And so what this means is that force can be used to move these particles around and do things to them. So they're susceptible to this ultrasound force. And one thing that happens is you can cause a massive amount of delivery of agent, probably through fusion of these vesicles with the cell membrane. So we've been working on that. Here's the non-targeted ones at baseline. Here's an outline of the cell with not much happening. The targeted ones, you can see, again, these little blobs out here on the cell. The green stuff is fluorescence on the particles that have gotten inside of the cell. That's fluorescent lipids. And you can see them actually transferring, like by this lipid exchange. You can see these little tails here as stuff floats off the surface and goes in and transfers over to the cell. If you turn ultrasound on, you get a massive amount of this transfer, and it's probably due to the interaction with fusion of these vesicles, which basically then combine with the cell membrane, deliver everything to the cell membrane, and then it flips over. And the fusional aspect of this is easily done with ultrasound. Just a little clinical ultrasound is enough to cause one of these vesicles to fuse with the cell membrane once it's targeted. But even if it's not targeted, in this special situation it'll work, but if it's targeted, it's probably 100-fold augmentation of transport of agent from these particles. One last thing, and this again is some stuff that Ann has been working on, compartmental modeling. And I just put this up as a teaser because we're doing this with Dave Sept and Rohit Pathu and Nathan Baker as well in one of our cancer grants, is to look at the ability to use the MR signal or an imaging signal as an input to a pharmacokinetic model, for example. So if you knew what the signal was and it was related to the concentration of something at local sites or in the bloodstream, you could do pharmacokinetic modeling with that. And here's just an example of one of those kinds of things where you can actually look at the time course of these particles in the bloodstream and at the site, for example, and have these multiple compartments. And all of these outputs, I won't go into any of these, but all of these outputs tell you something about these transfer constants once they're fit to these models. And it turns out that you can calculate these things, and these might be useful for figuring out how much drug you needed to put on a particle or how much of a dose you needed to give and so forth. So the nice thing about this is that you don't have to take a blood sample, you just take a picture and you can get the idea would be, if it works, you can take a picture and get the pharmacokinetic profile of this and probably the pharmacodynamic profile as well, which just means did it have an effect, because you can go back and image the tumor or whatever you were trying to affect. And so you can do PK/PD modeling with imaging inputs. And so to be able to do that quantitatively would be a real coup for drug delivery and molecular diagnostics. So to finish up, the clinical promise for nanomedicine, very early diagnosis of pathology. You want to be able to predict the disease course because you can follow it time and time again. You can follow it up with the same imaging modality that you use to diagnose it. Rational drug dosing for local drug and gene delivery. That just means that you can calculate the amount of drug that you put at a site and you can know that it got there, and then you can decide whether you need more or not based on whether you got enough there or what the effect was over some period of time, because you can use the imaging inputs to your PK/PD models. Quantifying the molecular response to therapy. In other words, did angiogenesis go away? Did the clot go away? Whatever you're looking for, did it go away? Or maybe you want to make angiogenesis. You cases, for example, of diabetic ulcers, you may want to make more blood vessels. So you put a growth factor there, like VEGF or something like that. So you want to follow that to make sure it grew enough. And finally, as surrogate endpoints for assessing drug efficacy, meaning that instead of, for example, doing the regular thing you do when you use a cancer agent and do a clinical trial, you give 1,000 patients this regimen, and another 1,000 patients get that regimen, and at the end of some number of years, you count up the bodies. I mean, it's pretty crude, but you have to wait a long time. It's certainly robust when you do that, but wouldn't it be nice to know sort of at the end of a week, instead of waiting for that long, that you were having an effect? And so surrogate endpoints for assessing drug efficacy, not just for clinical trials, but also for individual personalized medicine. So if you've got a tumor, your tumor is different than somebody else's tumor, and so you want to follow your tumor with this technique, and it's going to behave differently. So that's where the whole personalized medicine thing comes into play. So I think these things are all coming into clinical trials. In fact, the material that I've shown you has been licensed to a company in town called Carios. They should be in clinical trials for fumagillin anti-angiogenic nanoparticle therapy for some kind of tumor within about 9 months or so, and then some imaging agents for imaging those angiogenic components on tumors, and then some other atherosclerosis things. So there'll be a lot of these kinds of targeted systems coming out for both diagnostics and drug delivery into clinical trials in the next, say, two years or so. So with that, I'll quit, and we can go make some more atherosclerosis. And thank you for your attention, and answer any questions. Thank you.
So when do you think we will have something for EP imaging with MRI?
EP imaging?
Like transmembrane potential or intracellular calcium at realistic
Well,
time
you know,
resolution.
so what folks are doing with fancy schmancy agents is they're making calcium sensors. And so what happens is you can already do pH imaging, for example, various ways of doing it. You can do oxygen imaging, other sorts of things. If you want to do calcium imaging, you have to have something that calcium will cause to change, and that you can register a change. And there in fact, are some agents where calcium will sort of expose gadolinium. They're sort of hidden away. The gadolinium is hidden away, and then calcium comes in and activates some part of this. Depending on its concentration, it will expose the gadolinium, and therefore it will change the relaxation locally of the water. And you can see that as a shortening of something called T1 shortening. And so, but they're going to have them in very high concentrations. They're not very sensitive at the moment. It's not clear they're really going to work in human beings.
So what happened then to sodium? I remember you.
Yeah, you can image sodium, you can
ago.
image potassium. Again, low signals.
But also I think sodium buffers calcium, which basically stops the heart.
Yeah.
So
But if you're going to image sodium, you can actually you can tune your machine to sodium, or you can like you tune it to phosphorus. You can tune it to sodium, potassium, and other sorts of things. But the problem is they have really low signals. Sodium hasn't got much of a signal. Fluorine has a big signal. You've got enough there. Protons have a big signal. Sodium has a really low signal. So the problem is one of sensitivity. So when you look at a sodium picture, you kind of got to squint your eyes. It's sort of ugly, and it'll never get less ugly because there's only so much sodium there. But it is possible.
How difficult is it actually to manufacture this? If I show up to your front door with an antibody and a drug, what?
I'll call the police.
How long does it, and how difficult is it, how practical is it to produce this stuff? And is it really an expensive process, or is it something, investigators in the future can be able to say, I want to take my favorite antibody here that I'm looking at and tag it with this?
Yeah, there are sort of two answers to that. If you wanted to do it like you might do it for commercial applications, it would be impossible to afford, because all antibodies have to be humanized, and that's a $10 million process. I mean, you know, the antibody bandits will hold you up for $10 million to humanize it. But if you just wanted to mix it up with nanoparticles, there's a way of doing that where you can use avidin and biotin if you're going to use it in an experimental animal, but you'd never use that in a patient. And that's pretty easy to do, and we do that, and others of our collaborators do that. Now, if you have an antibody, the problem is, in our case, we don't want the Fc fragment activating anything, so we cut it off. The cutting of it can destroy it, and then the biotinylation of it can destroy it. So the process isn't like, give me your antibody and tomorrow come back and get the whole complex. You've got to figure out how to cut it, what to cut it with, where it cuts, how to get the biotinylation on it, and so forth. So you know, everything is different. So you're talking about a process that is going to require some amount of effort over maybe a month to work the system out. But you know, it's doable, and we've done it with VCAM, ICAM, PCAM, AVB3, fibrin, collagens, other sorts of things. So, yeah, just a matter of what you want to do. The one thing about it is it's not, the perfluorocarbons are maybe expensive. The antibody amounts you need in order to make a batch of this are about 100 milligrams. You'd never be able to afford this if you got it from one of the houses. So what we do is we actually grow them up from hybridomas, and we send out the juice and have it purified, and then they boil it down and give us back the dried out antibody, which we can deal with in gram quantities. Because in order to make this, you make pretty large batches. Some people make barrelfuls of it. We make, you know, maybe about that much of it, but the antibody would be very expensive. But for commercial use, it's actually quite nice, because the alpha V beta 3 is a small molecule. It's a chemical, and that's cheap. Perfluorocarbons, you know, reasonably okay. The lipids are okay. Gadolinium, it's not very expensive. Made in large batches.
And speaking of expensive, is this new drug you can hear about Avastin?
Mm-hmm.
Is that a targeted?
It's kind of targeted in the following way: it sucks up VEGF. So if you put Avastin in the bloodstream, it'll suck up the VEGF in your bloodstream with the vascular endothelial growth factors. And when VEGF goes down, the drive to angiogenesis goes down. It's in response to the 1-alpha. And so Avastin is used as a VEGF sponge, if you will. It's good for some kind of tumors, but for example, doesn't work in breast tumors. It causes problems in colon cancers. It actually causes perforations. Because you actually need angiogenesis to repair your gut. You're always sloughing off your gut, and if you didn't have blood vessels there, you'd have no way to provide nutrients to re-heal that. So there are some potential dangers to that drug, and in fact they just stopped, Genentech just stopped the Avastin trial for colon cancer because of that. They're looking over the data right now because of the intestinal perforations. But and it didn't work for breast cancer at all. But it's good for some things. It's targeted to VEGF, but it's not. It's an antibody. It's targeted to VEGF peptide, and it's not targeted in the way that I'm talking about, targeting delivering some drug like that. But it is a quote targeted therapeutic.
Clinical trials targeted to any specific pathology, cardiovascular pathology?
Well, as I was saying, the stuff that we're going to be doing is going to be targeted, for example, let's say to angiogenesis in breast tumors, maybe prostate tumors, maybe melanomas, because they're easy to get at. And that'll be proof of principle for the use of this targeted agent as a low toxicity, high therapeutic index tool that might have some imaging implications as well as some therapeutics, but that would be the trial that would be upcoming for us. Everybody's planning trials on these sorts of things. There's lots of different nanoparticles that are made with copolymers and block copolymers and tripolymers and so forth that carry drugs. Everybody's out to use these. Abraxane is a drug that actually, and Doxil, these are carried by liposomes, Doxorubicin, for example. So those have been approved, but they're not targeted. They're taken up by the tumor in the tumor cells themselves and by macrophages and delivered sort of by these other delivery systems, but they're not really targeted per se. So there'll be a lot of clinical trials coming up in the next year or two. The NCI is beating the drum for this kind of stuff because they haven't. Nothing else is happen.
Nothing is working.
Nothing is working. I mean, stopping smoking is a good thing.
Preventive.
Yeah, prevent.
Any other issues, questions to Sam? Well, thank you very much.